Meetings held remotely will require roll call votes for all action items. Meetings at a CCH board and committees will be held remotely until otherwise noticed, although we are expected to be meeting in person in May 2023 due to the determination that a public health emergency exists and will be ending. I'd like to call the meeting to order, and I'd like to ask the secretary to call the roll.
Director Harrington is absent. Director Story?
Director Story is present.
Thank you. And Chair Curry?
Present.
You have a quorum.
Thank you. The next regular meeting of the Managed Care Committee will be held on Friday, July 21st at 10:30 a.m. Public testimony. I'd like to ask the secretary if anyone has registered to provide virtual oral testimony or submitted written testimony to be included in the record.
We received 5 registrations to provide virtual oral testimony, and we have 1 written testimony that I'm going to email you in a minute, and we'll be posting it to the website. Additionally, one of the speakers who registered is unable to attend today, so one of the other testifiers will be reading her statement. Sharita Wright was unable to attend, so Rolanda Watson will be reading her statement after she finishes giving her own. So I will call Rolanda Watson. Are you present?
I am present. Can you hear me?
We can. Thank you.
Okay. Shall I start now?
Yes, please.
Okay, to the board and panel, good morning and thank you for your time. I am Nurse Rolanda Watson, working at Cook County Health for 30 years now. In addressing safety concerns returning to the field, while President Biden signed an end to the national health emergency, the public health emergency is not slated to be heard until May 11th. So I ask, why are we sending nurses to the field on May 1st without hearing the public health emergency decision? To make it clear, management sent a notice on April 14th directing nurses to return to the field, going to individuals' homes starting on May 1st. Given there is a police shortage in Chicago, one wonders how safe are our streets. So again, I ask, why are we sending nurses to the uncertain field on May 1st? Cook County Health has a duty and an obligation to keep its employees safe. It is untenable that integrated care nurses have no safety guide or protocol to reference when in the field and out of the controlled environment of the hospital or clinic setting. During yesterday's board meeting of finances, Dr. Bina Peters spoke of RN turnovers and recruitment. She mentioned there are not enough nurses to meet the demand, and the Cook County Health has over 830 vacancies. After hearing this, I was befuddled. If Cook County Health knows we have all these vacancies, know there are nursing crisis, know there's a recruitment difficulty with not enough nurses to meet the demand, then I ask again, why are we sending nurses prematurely back to the field of uncertainty with a lack of police presence, lacking safety protocols, thereby potentially accelerating nurse burnout, which may cause nurses to flee to county health for other facilities with better sign-on bonuses and retention packages. In addressing the lack of training on the agenda, I like to highlight it is not the nurse's competency training that is in question. It is the sheer non-existence of field training that will teach nurses in the field how to react for danger signs, ways to keep themselves safe, and tactics to react to a potential threat. RNs of integrated care are requesting the implementation of in-person duties be delayed until management discuss the impact of these changes to our working conditions, then comply with legal and contractual demands around caseloads, zoning, safety, and training. Thank you, Joseph Harrington, for looking into the turnover rate on yesterday. Thank you, Charles Jones, for the bio inquiries shedding a light on things. Thank you, Director Robinson, for praising HR and trying to fill vacancies and opening ideas about bringing retired nurses back to fill the void. And thank you, Robert Ritter, for clarity on retirees' public pensions being a roadblock in bringing back those retired nurses. And that is done. I'm done. Thank you.
Thank you. And I should have reminded you at the beginning, each speaker has 3 minutes, and when there's 30 seconds remaining, I'll remind you, and also when the time has elapsed. Are you ready to go ahead and present the testimony for Sharita Wright?
Okay, and will those 3 minutes start over again for her?
Starting all over.
Okay, so Sharita Wright wrote, good morning. My name is Sharita Wright. I recently started a position in complex care coordination in July of 2022. I've been at Cook County Health for almost 9 years now. I enjoy what I do here serving my patients. Since the pandemic, many things have changed in the world. It is not the best interest of us, it is not in the best interest of us nor our patients to return to the field and go inside the homes of our patients without proper preparation. That includes collaboration between NNOCRNs and management to develop safety plans, training plans, and other safety protocols. We have been very successful at getting our jobs done during the pandemic. We have to consider our travel and assignment zones need to be adjusted if we have to return to the field. We have been asking to meet with management to discuss these concerns for years, and we have been ignored. Please postpone the return to the field until RNs have safety training and workload measures in place. And that is all she wrote. Thank you guys, and you all have a wonderful, beautiful day.
Thank you.
The next speaker is Tiffany Blakey.
Good morning. Can you hear me?
We can. Thank you.
All right. My name is Tiffany Blakey, and I'm an RN working in the Health Plan County Care Division of Integrated Care. I have been an RN for 14 years, and I have worked at county. Next month will be 4 years. For the past 3 years, I have been working remotely to protect the safety of the patients and my safety as well due to the devastating effects of the pandemic. Last week on April 14th, NNOC nurses received the notice of May 1st, 2023. Integrated care nurses will have to return to in-person duties or will be subject to discipline. County provided RN 16-day notice to comply with this drastic change for our working conditions. What about my colleagues that need to prepare for proper child care? It takes more than 16 days to complete this process. We are unaware of what returning to the field looks like. This has caused anxiety amongst many of us. I have several concerns regarding returning to the field. Our safety needs to be addressed. I've done home health in the past for over 11 years, and the safety of our ends was a priority no matter where I was at. In case of an emergency, there needs to be safety plans in place to protect us. COVID is still affecting people in this country. We need COVID protections for the field staff, proper PPE trunk supplies, a training schedule so that we can become acclimated to this change in the working conditions. Will our productivity and expectations be lower and considered since we have now to spend time driving within the community, hospitals, members' homes, and even dialysis centers, as well as multiple meetings that we are expected to attend weekly? Cook County has a duty and obligation to keep the employees safe. Some of the neighborhoods that we visit are at an economic disadvantage and often plagued with violence. As an RN, it is my duty and obligation to operate at the top of my license so that I can provide the care to our patients deserve. As an RN of integrated care, the date in which we should return, quote unquote, to the field should be delayed until management discusses this impact and these changes in our working conditions and comply with the legal and contractual demands around caseloads, zoning, safety, and training. Thank you.
Thank you.
And before I call the next speaker, for the record, I wanted to mention that Director Harrington has joined us. And the next speaker is Ann Mangalang.
Good morning. My name is Ann Mangalang. I'm an RN working on the elderly division of the integrated care. I've been with Cook County for 19 years now, but with integrated care for less than a year. My colleague Rolanda has mentioned, covered a lot of stuff that we have are concerns for going back in the field. To be clear, integrated care RNs are not making unreasonable requests, with most of the major request concerns the development of safety plan or protocol as we return to the field. Cook County has a duty and obligation to keep its employees safe. It is untenable that integrated care RNs have no safety guide or protocol to reference when we are in the field. Out of the uncontrolled, controlled settings of clinical, in the hospital and clinical settings, we'll be going to neighborhoods that are economic disadvantaged and often plagued with violence. Furthermore, our assignments are not even necessarily clear or logical or efficient. An example of one of those concerns are travel zones for HRNs, which are based on geographic locations for our patient population. We cover 120 patients, members for a caseload. And driving around, taking time spent on traveling to these various locations will drastically decrease our productivity. Fewer patients will be seen, fewer financial resources for Cook County Health, and we know that integrated care has given a lot of revenues to this to Cook County Health System, and so going back to the field will greatly diminish our productivity because that would be spent a lot on driving around. That is all. Thank you.
Thank you.
Thank you. The next speaker is Barbara O'Brien.
Good morning. My name is Barb O'Brien. I'm a nurse representative for NNOC, and I work within the Integrated Care Affiliate of Cook County Health. As members of the Managed Care Committee, you know that the average enrolled membership per month is 390,000. You are also aware that the revenue from county care alone in fiscal year 2022 was $2.6 billion, more than double the amount of revenue generated from all other sources combined. And we heard from the Finance Committee just yesterday that county care is ahead of their budget for the first quarter of 2023, with a quote, pretty healthy gain of $11.5 million, unquote. This gain is in part due to the labor that is provided by integrated care RNs. On April 14th, NNOC RNs were notified that they must return to patient care duties in field sites that are not regulated by the county government. The notice stated that RNs will be subject to discipline if they do not return to normal operations. For the past 2 years, we have been demanding the negotiation of impact from our management and from the County Bureau of Human Resources, but management refuses to meet and to act in good faith as required by labor law. Since July of 2021, integrated care RNs have been requesting compliance with our CBA by convening a safety committee to develop and implement policies, procedures, and protocols for RNs working in the field. We have been requesting staffing plans, reasonable caseloads, and assurance of timely mileage and per diem reimbursement as outlined by our CBA. We have been requesting that our geographic zones return to prior pandemic policies, allowing more time with our patients, less windshield time, and a more efficient use of county resources. And those requests have gone unaddressed. We have been waiting for almost 2 years for management to fulfill their legal obligation to bargain in good faith. And when I say good faith, what I mean is that when management says that they will remedy our geographic zones in Q4 of 2021, they actually follow through with that. Integrated care RNs were given 16 days with notice with a threat of discipline. We have been waiting for almost 2 years. What is going to change in 16 days? In addition to the threat of discipline from our employer, who has a legal obligation to keep us safe, the lack of fiscal responsibility and management's ongoing refusal to fulfill their legal obligations of discussing the impact to our working conditions, the unilateral decrease of integrated care RN wages in the budget appropriation for fiscal year 2023 creates an existential threat to the nurses and to the patients that we serve. Members of the Managed Care Committee, county has, as an employer, has a duty to bargain in good faith. I am not requesting that in-person duties be delayed. I am demanding that county negotiate the impact of these changes to RN working conditions under labor law. The discussion itself is not the remedy. Thank you.
Thank you. Is there any further testimony?
No, we do not have any other testimony, but for the record, we have Director Bott who has joined us.
Okay, thank you. Next will be the report on health plan services. This will be presented by Ann Mangalang, who's the Chief Administrative Officer of Health Plan Services. He will review the report and metrics. No action will be required. He's only presenting information. Mr. Galena.
Thank you, Director Curry, and good morning, directors. I'll start today with our usual metrics. Let Debbie catch up the slide here if you want to go to starting with our membership. So as of April, we have just over 455,000 members. We've continued to see this number grow by 2,000 to 3,000 members a month fairly consistently over the past really over the past 18 months or so. Of course, we'll be talking quite a bit more today about redetermination, which will begin to impact these numbers in the second half of the year. The next slide shows our managed Medicaid market data. So this is market share, which has been really pretty consistent for the past several months. We continue to hang around the 32.5% to 33% mark on market share. And the rest of the market has been pretty consistent on overall market share data as well. The next slide shows our growth compared to the overall Medicaid managed care growth in Cook County. You can see that overall we've tracked pretty consistently with the growth in Cook County for the past 12 months. The next slide shows our membership compared to our budget. As you'll recall, our budget assumed that redetermination would start towards the beginning of this fiscal year. That we now know is really launching here over the course of April and May, with the first coverage losses we're expecting to occur in July. So we expect over the course of this year to continue to significantly exceed our budget, but do expect we'll see membership declines over the second half of the year as that redetermination process starts. The next slide shows our operations metrics in terms of call center. You do see some of the rebound in our call center metrics over the course of March 2023. And our claims and encounters acceptance rate has been fairly consistent, meeting our state target. The next slide shows our inpatient admissions per 1,000. You can see the orange bars here are prior period, the blue bars are current, and then there's some light blue shading that's a little bit hard to read on this slide that shows some of our projections. But generally, the blue bars or our current period have continued to track and trend downwards compared to inpatient utilization per 1,000 compared to the prior period. The next slide shows our overall claim payment metrics, which have, as you may recall, ticked up towards the beginning of this year as we went through some of the rollover and budget processes for the beginning of the year, but have now came back down to levels that we would expect right around the 30-day mark. And if you look at the next slide, you can see that same trend really in that 30 to 60-day category where some of those outstanding claims have come down. With that, our next topic that we're going to cover is redetermination. And so I'm going to hand it over to Carolina to talk through that in more detail. Sorry, Debbie, you can advance a couple slides.
Thank you so much. Good morning. It's Karolina Duszczak, Interim Chief Operating Officer. For the redetermination, as Aaron had stated, the state is requiring all of the Medicaid beneficiaries to go through the redetermination process to check if they're still eligible for receiving services under the Medicaid program that had been suspended during the public health emergency. And in the screen here, you can see that the first letter is going to start going out at the beginning of May. The members will have about 30 days to respond and provide their updated information to the state. And if they don't, they would lose their coverage by July, and that's going to correlate with our projection of the membership loss with members who no longer qualify due to the income and the members who did not renew their benefits. We go to the next slide. So we actually have the preliminary information. All of our members will have to submit will go to the redetermination process in the period of 12 months, but it doesn't happen all at the same time. The date is tied to the members' original date of applying for the Medicaid benefits. Based on our data in April, we are looking at the numbers per month of members who are due for redetermination in each specific month, with the high number coming in July and August. That's also tied with certain activities in the market when the members were eligible to join that plan. And we also know that the state is looking at all other data available in their system, like a SNAP benefit or some other benefits member might have, that require them to provide their income information to do something what is auto renewal. So it's a Form A when the member will automatically receive the healthcare coverage extension for another year based on the information in the system that the state have. On the slide itself, you can see the gray column is showing approximately number of members who would have to submit their updated income information per each month, and we will be assisting the state with the communication to those specific members each month. We can move forward. County Care had been partnering and developed the redetermination strategy. It's really targeting every single point of interaction with the members to remind them about what the redetermination is and what do they have to do. The state is sending the physical letters to the members, and we already had the campaign going on for months now with the members updating, reaching out to the members to update their addresses. This is the first step that the members might not receive the letter, so then they're not going to know that they have to submit the information. In addition to the physical mails and address updates, we are going to do the telephonic outreach. We're going to do the text message outreach. We partner with our providers to also have that information and reminders to members at each interaction, and all other vendors that we're partnering that might be interacting with our members to remind the members that there might be in that specific month when they have to renew. The critical information is what was on the first slide, that the member can only submit their information within that 30 to 45 days window when they're due for renewal. They cannot really submit it ahead of the schedule. The state system will not accept that information. So that's where all the effort and coordination to target the specific members per specific month. That's also important to make sure that the system and the phone lines at the state are actually functioning and everybody doesn't contact the state at the same time. We can move forward. So activities to date, we have been contacting the members on the member addresses. We've been doing the real time addresses with the state database. We already roll out the education to all of our providers. We have training with the providers, with the communities. We also had recordings to our members, and we have the broad social media campaign about what the determination is and why it is important to respond to that letter coming from the state. We are in process of currently scheduling the calendars of event. We're going to be partnering with the Cook County Health team to have an event on site in the ACHN clinic and other provider location to provide the assistance in the communities to members that maybe don't have the access to internet, members who don't know what to do with the letter. So to have the real person, in addition to have the telephonic support, text message, phone calls, and emails. And lastly, we actually developed the incentive for the members. We really want to make sure that the members respond within the 30 days. We want to provide the reward to the members that they actually completed their paperwork timely. There is a process when the member can be reinstated once they lose the coverage, but that is causing a lot of administrative work and can potentially impact their access to care if they don't submit the documentation when they're due in specific month of the year. Okay, move forward. So we outline all of our partners who are currently integrated to receive the data and information to flag the members in their system, including our new Food Smart partner, care coordinators, and one of the very important point is that we're able to also partner with our PBM and pharmacy. So member going to pick up their medication, they also going to get a reminder and they're going to get the printout with their medication when their due date is. So we're really trying to contact the members not only with the education of why is that important, but also remind them if they are in that 45 days window to submit their paperwork. We can move forward. I'm gonna give it back. I can move, stay here on the member rewards. So from the strategic initiative, we one of the things that County Care is doing, we in addition to the covered services that there are defined by the state of Illinois, with the what are the covered services, County Care is offering benefits that they're supplemental benefits, and we have a whole strategy about how do we develop those rewards for the members to actually work on our HIDAS measures, on our quality behavior health, to really incentivize preventive health and healthy behavior. On the annual basis, we do an analysis on what rewards we have in place, how do we compare to the competitors, how are the members reacting to the rewards that we have in place, are there any opportunities based on the feedback that we get from the members itself, as well as from what we see in the data itself. Throughout that evaluation, we identify that families with children are those who are the most engaged in our reward program. We also saw that the members who are earning the reward, so they're performing the healthy activities, but also are activating their card and spending their rewards, they're more engaged with the health plan, so they're staying longer with our health plan. We know that staying with the health plan gives us more time for the care coordinators and other activities to really provide them with the services they need and establish those relations, but also their medical costs was lower if they're engaged in the activities and with the health plan. We can move forward. So in 2022, overall, we had 225,000 members earn at least one of our rewards. We loaded 4.5 million into the rewards for our members, and members can spend their rewards on groceries and on different over-the-counter pharmaceutical items. One of the things that we were able to identify that there was a limited, that was a limitation where the members can spend their rewards. It was just certain retailers that they could go to, and we were able to transition the program to open, that is more broadly open program where the members are earning the rewards on the Visa, and we see the shift in where the members are spending their money. Groceries and drugstores still stay at the top two categories, but we see the transportation services, so gas station and utilities like electric bills are also the places where the members are spending the rewards earned through our programs. In 2022, we also make changes and add additional rewards that are in line with our quality pillars and our goals for the year to drive the preventative health activities, and increase the amount for a couple of the rewards that were already in place. We can move forward. Now I'm going to hand it over to Dr. Collins. Thank you.
Good morning, everyone. I'm going to cover some of the strategic arms for the health plan now. Just an update on our vaccination rates. If you look at this slide, as of February, actually 51% of our members had at least one dose of the COVID vaccination, 21% fully vaccinated. There was a request to look at some ethnicity data as we continue to sort of target specific populations. And you can see the Asian and Pacific Islander population had the highest rate of vaccinations. We also found, as we looked at the data for those that have been vaccinated, the higher rates were found on both the north and west sides of the city. So as we look at strategies for additional vaccination opportunities, we know what areas to focus on. Next slide. We then took one step further and began to look at the CDC baseline rates in conjunction with our health plan rates. And you can see for that high-risk population, those 50 and above, our vaccination rates are highest, 70 to 76% for at least one dose, and those fully boosted 46 to 57%. So continuing to look at strategies on how we vaccinate all populations, but especially those that are higher risk. The next slide highlights just some additional information that we learned from our vaccination rates. Two very important things. Those members that stay with us the longest, the graphic at the top, if you look at eligibility span, those members that have been with us 3 or more years had the highest vaccination rate at 56%. And again, PCP, empanelment, and visits and engagement are also the other key factor when we look at vaccination rates. Those that actually were engaged with their PCP rates had a vaccination rate significantly higher than those who did not, at 73.6%. So again, as we look at our PCP engagement program, another highlight of why it's really, really important to have our members engaging with their primary care physicians. Next slide. I'm going to review now some of our newer programs that we've implemented this year. Our first program is our kidney care program. The goal is to identify those members that, number one, have early kidney disease so that we can intervene and prevent, hopefully, dialysis, but also to take those members that have later stage disease and those on dialysis, and using analytic modeling, how you begin to not only intervene early, can we get them to transplant earlier? How we provide wraparound services to them. And that's what we will hope to do with our new partner, Interwell, with our kidney program. The next slide. We just rolled this program out in March of this year. Through that predictive analytics, we identified 2,600 county care members that fit the criteria based on laboratory data primarily, and now they are being matched to their interdisciplinary team. The great thing about the program is not only is it nephrologists and their primary care providers, but it's also dietitians to focus on diet, social workers to help eliminate some of those social risk factor burdens that we know, and then pharmacists to really look at contraindications to specific medicines. Are there additional interventions that need to be done? And then providing that entire whole patient care model with the expectation based on modeling at the very beginning that we'll have a savings of approximately $10 million annually for the care of this particular population. Mr. Harrington, I see your hand.
Yeah, I was wondering when you might expect to see any cost savings moving forward. Have you projected out when you might start to see cost savings based upon this?
We'll probably start to see some initial cost savings for that lower risk population 6 months, so beginning of Q4, and then for that later stage population, they're estimating anywhere from a year to about 16 months.
Thank you.
Sure. Next slide. The next program is to provide an update on the flexible housing pool. The flexible housing pool, there are many components and many investors. County Care, through our quality reinvestments into the community, pledged $5 million to the flexible housing pool. That would, at the end, be able to house 67 of our members with 3 years of tenancy supports. We focused initially, with the help of our lived experience advisory group, to focus on members that were experiencing homelessness, but also had severe mental illness, in addition to substance use disorders and families with children. We've now extended that to also our justice involved, in addition to pregnant persons, because we see a need there also. To date, we have 54 members that are housed. We actually had 2 members that were lost from the program, 2 members that died, and 2 that are currently in outreach. And our goal is to hopefully be able to close out that 67 by the end of 2023. Mr. Harrington, I see your hand.
Yeah, what ancillary services are available besides housing? Once you get someone housed, is there a support team, and what happens in collaboration with just making sure someone has stable housing?
Absolutely. So that's the tenancy support part. So number one, teaching them what it means to have a home, how you take care of your home, how you pay your bills on time. Also, there's a care management team and social service team that works through any additional needs that you may have. So simple things as towels and sheets and pots and pans, to more extensive of what does it mean to be a good neighbor, how the importance of also, as part of being housed, the importance of you engaging with your healthcare team. team. So that tenancy support part is all of that, not only housing, but everything really at the end of the program. The hope is that with the housing, in addition to the tenancy supports, you're able to live independently and stay housed, which is the goal of the program at the end of the day.
So how
Next-
long would you?
Yep, go ahead.
So how long would you think it would take to have enough data to show that there's been some positive or negative impact as a result of this? 6 months,
As
a year?
as a resort specifically of housing or of the tenancy supports? Or both?
Both the housing and the tenants.
Yep, next slide. I think we can get into that when we look at the slide, the data on the next slide. We do have some preliminary data looking at 2018 through the end of 2021, a total of 990 households that were serviced in the flexible housing pool. What we know at this point is 94% have at least a 12-month retention rate for stable housing, which is great. The outcomes that hopefully will lead to ultimately being able to talk about how we use this as a source to improve health. We saw a 33% reduction in inpatient stays, a 19% reduction in emergency department visits, 22% decrease in recidivism for those that had Joe events, and really an overall decrease in medical costs. The other important thing here is that this was done even in the midst of the pandemic. So when we know that there were heights of homelessness and heights of hospital utilization for this particular population, there were drastic decreases in utilization. We also saw a 30% decrease in mortality. As we look not only as housing as healthcare, but as a point of equity, 74% of those that were housed were African American, 38% of those were justice involved, and almost 40% of the population were youth. So when we look at the outcomes, not only of utilization, but the impact on the community, I think the preliminary data that we have here shows exactly what we were hoping to show, that we know housing is a form of healthcare and really should be a funded source of healthcare for this particular population. Mr. Harrington, does that answer your question?
Yes, it does.
Okay, thank you. The next slide is just really a graphic of what I said. 2018, which is the first two bars, is the baseline year. And you can see whether we look at inpatient stays or whether we look at ER visits, there was a continuous decrease year over year, which equates to not only savings, but quality of healthcare and quality of life for our county care members. County care actually was 21% of the entire flexible housing pool population. And now that we have this data, beginning to have some conversations, not only with other investors to invest in the housing pool, but also conversations with HFS about how we begin to look at housing as a subsidy of healthcare, how we now begin to include this in rates so that we can look at some form of sustainability over the next few years with housing. So definitely more to come, but the preliminary data is absolutely fascinating in terms of what we can do when we provide housing for a very complex set of members. Next slide. The next slide, again, as we talk about equity and community engagement, is a new program around domestic violence. We looked at the data for our membership January through December of 2022. You can see there were a total of almost 120,000 respondents. 822 distinct members, though, responded yes to a red flag around domestic violence, whether they were afraid of their partner or a family member, whether they had been physically or emotionally or sexually abused. So we know there's a need there. Some very interesting data from here is that 40% of respondents in this small cohort were male. And what we know about age groups, about 50% fit in that 19 to 29 range. From there, we then began to have some discussions about what a program would look like and what we as a health plan and a enterprise could do around domestic violence. Next slide. we began to have some conversations with some of our community partners about what would it look like? Do we need, how do we increase our workforce around this particular area? Do we have a dedicated team or a dedicated group that we're working with? And what other opportunities can we provide in terms of emergency shelter, permanent supportive housing, advocacy, and legal counsel for this particular population? So we're starting to look at all of that. We're looking at system enhancements in terms of how we improve our screening questions, not only to increase the number of members that we can impact, but also training our staff on how to ask very sensitive questions to allow people to feel comfortable to answer those questions so that you can intervene. Where we are trying to decide if we will have a team within the health plan, or will we have an outside entity that will help us with this, and we're working through that. But we know a key part of it is housing, and really emergency housing. So excited that we're starting to train. We've trained about 56% of our staff to date, just in about 7 days. So really looking to get the rest of our team trained, and then beginning to look at the other components of how we engage, house, and advocate for this particular population. So more to come on that probably in the next few months. Next slide. And our last program, again, which is phenomenal, I think, as we talk about equity and moving the needle outside of the healthcare sector, is our food care program. We did an RFP and are now partnering with Food Smart, in addition to several local farmers, local suppliers, to really look at how we address food insecurity, nutrition insecurity, improve health equity, and really access to healthy food for our membership. Phase 1 was an emergency meal component. We've delivered about 1,100 meals since rollout 1/1. The second part of that is really access. How do we begin to take our 450,000 members and educate them? How do we teach them how to read food labels? An opportunity to talk with a dietitian about, although you may live in a food desert, how do you take what you have access to and make it more healthy? How do you take what you have access to and cook? Not so much the fried component that we so often see, but how do you still engage and eat healthy and enjoy what you eat? How do you begin to know the impact that food has, not only on your weight, but also other health conditions? And the other component of it is, we know that a lot of our members are also probably able to have other subsidies around food. So ensuring that you ask the question and support them through that process. What we've learned in this process is that a lot of our members don't have enough money for the whole month for meals. How do we begin to stack on those services? So not only do we talk about, as Carolina talked about with rewards, you have a food card there. You get additional incentives when you complete the food quiz here within the platform. You now also have SNAP on top of that, and additional potential rewards for buying healthy foods. So the goal is, you're worried about food maybe half of the month now. How do we move that trajectory to, you can go a whole month and food not be an issue in terms of where it's going to come from and how you get it? And then the last component is really looking at medically tailored meals with a focus on primarily high blood pressure, diabetes, and obesity, in conjunction with our pregnant persons, and really taking it one step further. We know that diet plays a significant role for those particular diseases, and all of the literature has shown when you impact what folks eat with those diseases, you make an impact on their blood pressure, you make an impact on their hemoglobin A1C, you make an impact on their weight, and all three of those decrease their risk for all of those downstream ramifications. So stroke, worsened heart disease, heart attacks, in addition to end-stage renal disease and the need for dialysis. So our hope with this program is that we will be able to impact not only components where there's food and nutrition insecurity, but also components where there are some chronic conditions on top of that. Ultimately a win-win on both parts, because we also then know that a healthier population is a savings for us, which allows us then to invest in other areas where it's not covered potentially for Medicaid. The next slide looks at just some of the information we're going to look at. Of course, we want to be able to measure our success. So how quickly are meals getting into the hands of our members? What is the utilization? It does us no good to have a program that no one is using, ensuring that our members know about it, providers know about it so that they can refer and we can get members the meals and services they need. When we identify members that have needs, are we connecting them to other services? Are we connecting them to housing if housing is a need? Are we connecting them to our care managers so they can intervene? Are we connecting them to their primary care physicians? So all of that's important, and this program is just another way that we'll be able to do that. And then all of those other parameters that we talked about with diabetes and high blood pressure and obesity. Do they have the supplies that they need at home? It's always amazing each and every day when I get an email about a blood pressure cuff. Yes, everybody that has high blood pressure should have a blood pressure cuff at home, and they should know how to use it. And this is another team that will ensure and help us do that for our members that have these particular diseases. So really excited about this. We should have some preliminary metrics probably in about 6 months. Those metrics around really weight sustainability, A1C sustainability, blood pressure sustainability, probably a little longer, some of the data anywhere from 9 to 12 months, but really looking for us to be able to move the metric on food insecurity for our Medicaid members. Next slide. Aaron, I don't know if you want me to take this, but I can. But some of the other points that came up that we wanted to make sure that we included were, how were we going to evaluate the success of our food program? I gave you a little bit of that. There was also an ask around COVID, ethnicity, and race. We talked about that today. And the other one that's not included here is what was the age distribution for those members that responded yes to those domestic violence and intimate partner violence questions and that. So we're continuing to grow each and every day. But I think hopefully just through these few slides, you can see that as a health plan, we believe that healthcare goes outside of the walls of our institutions and that we really have to get to where our members are in the community and really get to those non-health related needs in order to move the needle on the healthcare needs. So happy to answer any other questions if there are any. Otherwise, I will turn it back over to Aaron.
Thank you, Dr. Collins. And I think that concludes our presentation. So happy to answer any questions or any questions for the team.
Hi, I just would like to comment, Aaron, and thank Aaron and Carolina and Dr. Collins on a strong presentation here. It certainly seems to demonstrate the efficacy of these programs, and they're all moving in the right direction. Housing, domestic violence, and the food. And I would ask one question. Most of these take investments not only from the county entity itself and some of our partners. As you talked about the 53 individuals in the homelessness that have been housed. Is there an upper limit right now based on the current investments, or do we still have additional capacity that could accommodate additional individuals?
Let me back up 1 second, then I'll come back and answer your question. So the 54 that we have housed now is just our investment. There are over 1,000 folks that have been housed in general in the flexible housing pool for all of the funding. There is some additional funding now that we have through ARPA for an additional 100 beds for the system. 25 of those will be county care. But I think the concern now is if more investors are needed. Until we are able to sustain the program and really look at it being a benefit and how we tie it into a Medicaid service and Medicaid rates, more investors are needed. But that's where we are now in terms of volumes. And I don't have the total number of dollars invested, but there's definitely still room to house additional folks.
Okay. Thank you.
Yeah.
Well, again, shows great promise here, and I look forward to continuing to receive updates over the next few months. It's certainly that 6-month mark when we may have some substantial numbers to show how effective the program's been. Thank you. Anyone else?
I would just like to echo what Director Curry said about the presentation this morning, Aaron. Dr. Collins and Catalina. I'm just so impressed with the work that you guys are doing. So thank you for your commitment to uplifting those that we serve in the space called Cook County Health. And it's just great work. Great work. Thank you all.
Thank you.
Thank
Okay.
you.
Okay, thank you, everyone. With that, no action or motion is required. This was a presenting information only. I'd like to move to the next agenda item for action items and to review the January 20th, 23 meeting minutes. And I'd like to ask if there are any corrections that are needed to be made to these minutes. Okay, hearing none, then I'd like to entertain a motion to accept the minutes of the Managed Care Committee meeting of January 20th, 2023.
So moved, Director Harrington.
Second,
It's been moved and seconded. All in favor?
Chair Curry, sorry.
I'm sorry, yes.
Could we do a
Yeah.
roll call, please?
Yes, I'm sorry. Thank you, Dan.
I know it's a minor item, but just to be.
You're correct.
hey Debbie,
Okay,
everybody's trying to get out in front of your work.
I
No,
know.
I'm.
Okay, roll call on the motion to accept the minutes. Aye or nay, Director Harrington,
Aye.
Director Story,
Aye.
and Chair Curry.
Aye.
You have 3 yeas and 0 nays.
Okay, the motion has been made and seconded. And let's see, that concludes our business then. Let's see if I have anything else I would do here then. The agenda has been exhausted. And so may I have a motion to adjourn? There will be no need for a roll call.
So moved, Director
Second.
Harrington.
Okay. It has been moved and seconded to adjourn. Has been a second. All in favor?
Aye.
No roll call. Okay, the ayes have it, and the meeting is adjourned. Thank you.